May I now invite, it's my pleasure to invite Dr. Muna BHENDE, a teacher to many of us. She has great insights into macular degeneration. It's my pleasure to invite Dr. Muna BHENDE, Deputy Director of Retina Service at Shankar Nethralaya, Chennai, to give her talk on edible presentations of AMD and PCV.
Can you see my slides and hear me?
Yes, madam. Please go ahead.
Yeah, thank you to VRSI and Anand for inviting me. And it was an honor to share the stage with one of the greatest teachers, Dr. Amut Gupta. I will be sharing a few cases on atypical presentations of AMD and PCV. These are just typical pictures and the classic definitions of the two conditions, and I'm going to share a few atypical cases with you today. Taking off from where Dhananjay stopped, this is an elderly gentleman with a typical diabetic retinopathy. You see the hard exudates of the macula, the hemorrhages. He has an atrophic scar in the macula of the left eye. Both eyes had temporal disc pallor. This was the fluorescein angiogram, which showed an ill-defined stain at the macula in the right eye and staining of the scar in the left eye. Along with pan-retinal photocoagulation, he underwent an injection of ranibizumab in the right eye. And a month later, you see a reduction in hard exudates and hemorrhages. He felt better, though his vision remained at 6, 9, and 6. On the left, you see his OCT showing a good anatomical result. A lot of the edema has gone away. And you see this regular elevation of the retinal pigment epithelium just adjacent to the fovea. I called him back in a month's time, and he reported with a sudden drop of vision of about 660 in less than a month. And the significant difference I could see on the OCT was an increase in the area of RP undulations under the fovea and some shrink. The left eye was the same. We did an OCT angiogram at this time, which showed there was an underlying neovascular membrane at the fovea. Because of the unexplained drop from 6.9 to 6.60, we evaluated him for possible optic nerve pathology since he had a temporal pallor to start with that was negative. And systemic features, as Anita mentioned, always look at systemic features. They were significantly deranged. We sent him back to the physician. He came back in a month's time with the diabetes under better control. And you see an increase in size of the neovascular membrane under the fovea. He's just had a second injection of ranibizumab. I'm waiting for him to come back. This was the OCT angiogram of the left eye. Now, the combination of neovascular AMD and diabetic retinopathy is not well studied, but there has been the occasional report, and they show that vision is stabilized and there may be a stable or improved diabetic retinopathy stage throughout follow-up. So I would name this case as when the obvious overshadows the occult, and also makes a case for the role of OCT angiography in diabetic macular edema. My next case is a gentleman I first saw in 2019 when he presented with a large scar in the macula in the right eye and some macular fluid and drusen in the macula in the left eye. His vision was 6.6 and 6 in the left eye. This was his fluorescein angiogram and ICG, which showed features suggestive of a small occult choroidal neovascular membrane, dilated choroidal vessels on the ICG angiogram. OCT was typical for an active type 1 CNV. So over the next 6 years, he received injection bevacizumab on a PRN basis, maintaining 6.6 and 6 throughout. 6 years later, he presented for a routine checkup, and I found that he had developed a nasal juxtapapillary choroidal neovascular membrane and a similar one in the other eye as well. Now, this was his OCT, which shows there was barely any fluid at the macula, but there was a type 2 CNVM adjacent to the optic disc in the left eye. This was his fluorescein angiogram and ICG at presentation, and this was the fluorescein angiogram in 2015 showing the CNVM adjacent to the disc and an ill-defined mottling at the macula. But what clinched the diagnosis was the swept source OCT, which showed the grossly thickened peripapillary choroid and the very large dilated choroidal vessels. And if you look at this picture, you see that the thickening is more on the nasal side of the macula than the temporal. And over the next few years, he received multiple injections of anti-VEGF, maintained a vision of 6, and 6, but you see this membrane continued to grow and encircle the optic disc. And this was the swept source OCT angiogram, which looks almost as if the CNVM is strangulating the optic disc. The large choroidal vessels are significantly dilated in the optic disc area. And what was also curious was that there was this original subfoveal type 1 CNV, which remained distinctive from the peripapillary CNV. Now, peripapillary pachychoroid syndrome is recently described, but what we know is that it does not come with choroidal neovascular membrane. So this case is a little different, though there has been an occasional case report. So I would name this case as, when you think all is well in the macula, always remember to look around the optic disc as well. And it also tells us that CNV can occur in peripapillary pachychoroid. My third case is an elderly gentleman with avascular pigment epithelial detachments in both eyes. Over a 3-year period, you see an alteration in the contour of the pigment epithelium, detachment with some surface irregularity, and occasional cystoid spaces that appeared and disappeared. And this happened in both eyes. In 2017, when I saw him, I saw these little patches of atrophy on the surface of the pigment epithelial detachment. You see them well on FAF imaging as dark spots. The OCT shows that the pigment epithelial detachment has a fairly dense configuration. There are some cystoid spaces above the PED, and the typical oval hyperfluorescent lesions, which are well defined, seen at the surface of the pigment epithelial detachment and the margin. This was an area of pigment epithelial atrophy. There was no evidence of choroidal neovascular membrane. And in the left eye, the PED had flattened, leaving behind atrophic changes. Now, over the next 1 year, the pigment epithelium detachment flattened, as you can see here, and what we thought was a good result. But if you look carefully at the edge of the PED, there is something new developing. There has been an irregular elevation of the retinal pigment epithelium with some involvement of the inner choroidal layers, and this occurred exactly at the margin of the original pigment epithelial detachment. A fluorescein angiogram and ICG at this time showed an increase in the areas of RP loss compared to 2017. But just look at this small spot here, which showed up like a small ink blot leak, which corresponded to this area of RP irregularity. And we did an OCT angiogram, which showed new vessels in this area. We advised him a very close follow-up because there was no fluid here. He was traveling abroad and subsequently underwent 3 injections of bevacizumab while he was abroad for an increasing size of the neovascular membrane. When I saw him in February 2019, he was maintaining a vision of 6, 9, and 6 in this eye. You see the increase in size of the pigment epithelial, fibrovascular pigment epithelial detachment, significant increase in size of the choroidal neovascular membrane. Now, retinal pigment epithelial apertures are a recently described entity. They are round discontinuities either at the apex or the base of an avascular PED. And curiously, there is no change. The PED appears as smooth, unlike a retinal pigment epithelial tear. These are known to either increase in size or develop new lesions, and most often are unassociated with choroidal neovascular membranes. So I would call this case as when you thought it was the end when the PED flattened, and you thought that was it, this patient developed a new vessel at the edge of the PED, which was unusual. And this case also taught the role of assessing individual lesion components to pick out the lesion that was more likely to cause a problem. My next case is a 34-year-old hypothyroid lady who presented with blurred vision in the right eye due to this submacular hemorrhage. If you look at her fundus, very distinctive multiple pigment epithelial detachments scattered all over the posterior pole with some drusen-like lesions temporal to the macula. This was the fluorescein angiogram she brought with her. showing hypofluorescence in the late stages corresponding to the PEDs. And this was what clinched the diagnosis, the ICG angiogram, which apart from showing blocked fluorescence, the area of the pigment epithelial detachment, and an active leak subfoveally, it showed these classic donut-shaped lesions, which are very typical of large colloid drusen. And this is the crossover OCT VRSI showing that there was a hemorrhagic notched pigment epithelial detachment. You see the OCT of the left eye showing multiple typical pigment epithelial detachments of large colloid drusen. After one injection of ranibizumab, the submacular hemorrhage disappeared, the lesion had flattened somewhat, and now we were able to pick up the vascular network under the fovea. And this was the patient after just one injection at 3 months, her vision was 6 uncorrected. Choroidal neovascularization and geographic atrophy can occur in patients with large colloid drusen. However, these occur usually later in life. And abnormal quiescent neovascularization in these eyes has also been described, and more recently, a case of polypoidal choroidal vasculopathy. So when the patient profile does not fit, a young patient who looks like she has AMD, there are 3 things you need to think of: cuticular drusen, large colloidal drusen, or autosomal dominant radial drusen. And this is my last case, a gentleman whom I have been following since the year 2007 for possible CSR in the left eye. In 2011, when I did an OCT, I found this little excavation of the choroid at the fovea with 2 hyperreflective structures within it. We observed the gentleman on a regular basis, and over a period of time, he developed a peaked pigment epithelial detachment along with subretinal fluid at the fovea, and as a PCV lesion that was just bordering the area of choroidal excavation. He underwent multiple sittings of anti-VEGF injections as well as photodynamic therapy. In 2015, you see the Swept-Sos OCT shows the large choroidal vessels typical of pachychoroid adjacent to the area of choroidal excavation and the polypoidal lesion at the base. The ICG confirms dilated choroidal vessels as well as the polypoidal choroidal vasculopathy lesion. And over the next few years, and he continues to have injection aflibercept on a PRN basis and maintains a vision of 6/6 in the side. This is his OCT angiogram showing the branching vascular network. And we now know that focal choroidal excavation is not just a curiosity, it can be associated both with PCV and choroidal neovascular membranes. So something we think or thought was a random imaging curiosity landed up with a lesion that needed to be treated and continues to be treated almost 9 years down the line. So this is the summary of my cases, and I look forward to comments from the panel. Thank you so much for your patient listening.
Thank you so much, ma'am. And I think each and every case that you showed had a very important learning, and it's always a pleasure to see how beautifully you image and follow up your cases. I'll just invite some quick comments from our panelists, starting with Dr. Shanmugam, please.
Thank you, Dr. Munna, for the wonderful cases. Like each of them, we could learn something or other. I had a question. The RP aperture, all of them seem to show some kind of a leak. So how would you differentiate it from the underlying CNVM? And why I see that like you've not treated them even if there was some leakage on the angiogram. So what stopped you from treating?
Yeah, that picture described to be very typical of an RP aperture with the intense staining on the surface and some fuzziness at the borders. But we did an OCTA, we did not find any neovascular membrane there. That's why we decided not to treat. And at that time, probably I was not even aware that such a thing existed. It was just a curiosity. I think the first reports came just around that time.
Dr. Anita, any comment from you?
You're muted, Dr. Anita.
Yeah, the one with the PED and getting CNVM at the edge of the PED, often, PED occurs at the edge of an occult CNV. So it's possible that the CNV was there for a long time and was invisible because there was no blood flow through them. And, when the olden days, when we didn't have anything else but focal laser, we'd go and treat this if they showed a leak, and then you'd get a rip because they would be anchored at that edge. So question is, are all our imaging modalities able to pick up occult CNVs? Even OCTA won't pick it up unless there's flow through the CNVs. And, sometimes these CNVs have been sitting there for a long time with no flow. They're more like cords rather than tubes. And Gas showed that in many of his histopath slides of AMD. So it's something that we have to be aware of, and you treat it only if you see activity, and definitely watch the edges of the PED. That's where they're sitting around. And colloid drusen, it's kind of like a larger version of cuticular drusen. And so I think now that we have imaging, we kind of splitting everything into little kind of compartments, and we don't know where the overlap is. But I think the one thing to remember is, even if you call it colloid drusen, that it can have features that can go with the other ones. So we just have to keep an open mind about kind of splitting hairs about all these diseases with imaging. And I think all the imaging gurus are trying to rename and kind of split everything into multiple different sub-entities, which I don't know if that helps us, or I don't think it helps us that much in managing. And I remember when we didn't have OCTs and we only knew clinical findings, or you used an FA, cuticular drusen, Don Gas taught us he thought it was excrescences of the pigment epithelium's basement membrane. And he thought that's how it was different from exudative drusen, and still a histology of his eyes. But now we know that lots of patients who have cuticular drusen, the young patients, their 30s, 40s, or 50s, down the road, they can develop exudative drusen, AMD drusen. So there's probably, the same eyes can develop something else down the road. And when you go back and look at all these cuticular drusen patients in older age group, they have some features that are cuticular and some are exudative. So I think I used to be so kind of compartmentalized about what he taught me, and now I realize that there's a lot of overlap and other diseases can occur. So we keep an open mind. And I guess the most important thing is to look for evidence of CNV in all these diseases. Choroidal excavation, pachychoroid, again, pachychoroid, posterior pachychoroid is really CSR, that is more localized to the back. And you can rename them into all sorts of compartments, but the key thing is to look for unusual features and kind of catch them and treat them.
I have a question to Anita and Dr. Muna. These drusen, how are they different from the ones associated with glomerulonephritis or the renal disease? Are they looking different?
What did you say? What is the last word?
The renal disease, the ones associated with renal disease. Yes.
With the type 2, the complement disease. See, that's so rare. It used to be called MPGN type 2. Now we call it dense deposit disease or complement activated disease. And everything's getting renamed and sort of organized. I think they all have a type of cuticular drusen where things are occurring at the basement membrane of the pigment epithelium. Overall, these diseases cause changes to the pigment epithelium, blood outer retinal barrier breakdown, and they're nidus for CNVM because the Brooks membrane breaks. So I think if you really have the renal disease, then it is MPGN type 2 or the dense deposit disease. And if you don't have that, the same features can be seen in other things, say also in North Carolina macular dystrophy. You can see it in patients with Malatia levantinase. They're all changes occurring at the pigment epithelium, but some are very specific. Of course, Malatia levantinase is very specific. They have really kind of very sort of excrescences coming out of the pigment epithelium's basement membrane. And they're all types of cuticular drusen, which is what Don Gas had called. And if you go back and look at his original paper on cuticular drusen, the same eye histology that he had described in light microscopy was taken by the Iowa guys. He sent it to Iowa, and they studied the constituents in that material. And the material that's in the cuticular drusen histologically is the same as what you get in age-related drusen. So I think it's the same material accumulates, but they accumulate in slightly different fashions in different diseases. And eventually they all cause break in Brooks membrane and cause CNVMs. So I think down the road, we'll probably know a little bit more details about these things. And
yeah, I think there was a recent report on the different kind of drusen, and I think everything else has an association. Like Malatia has a definite genetic defect. and the cuticular drusen can be associated with MPGN. This is one of which comes under the unknown category, where they look more like serous pigment epithelial detachments, multiple when you look at it. So this comes under sort of a doubtful inheritance. I think nobody's established it, and that's where it's split up.
And it's very, I mean, if you look at them, they're symmetric sometimes. And you look at somebody's eyes, they have the temporal macula. It's not in the macula, it's outside the macula. And they're very symmetric. So there's something that we'll learn down the road. And some of them are in the macula, some outside the macula. Most of them are younger patients, if you see them when they're early on. And I think you can name them all sorts of names by the appearance, but who knows what they'll all be eventually.
So I think since we are running late, I'll just take quick last two comments, one from Dr. Dhananjay and then to Dr. Jay.
Yeah, my comment is to Muna, just to inform you that this RP aperture, which you read about in retina, I and Anand described it about a decade ago in Ostley retina actually, and that paper went unnoticed. Just for information. Thank you.
I have cited your paper. I just wanted to make two quick comments. One was the AMD patient with diabetic retinopathy. I'm just wondering that the visual acuity which deteriorated, that could have been because of the intraretinal fluid accumulation. So maybe combining with Ozurdex and continuing the anti-VEGF therapy may be another alternative. The other comment I had was about the interesting case of PPS with CNV. As you beautifully showed that the thickened choroid and the type 2 component of CNV, and we saw that the CNV actually grew in spite of continuous anti-VEGF therapy. So I was wondering that maybe offering a combination with PDT may be a good option in these cases, because one of our recent paper in AGO, we showed with Javid Saraf, we showed that PDT is a very good option for PPS associated fluid. So maybe we could think of PDT in PPS associated CNV as well.